So welcome everyone. My name is Amir Bedad. I'm here with two of my colleagues, Dr. Jyoti Patel, our medical oncologist with specialty in lung cancers, and Dr. Mohammed Abazid, who's our radiation oncologist. We're going to present a few cases for you in this molecular tumor board.
I'm happy to present some of the cases that we've been seeing lately. It's certainly been a rapidly changing world. And I have come to rely on the sort of multidisciplinary forum to find the best path forward for our patients. So the first case is a patient I've known for some time. She's a 71-year-old remote smoker who developed cough in 2014. At that juncture, she was found to have a left upper lobe mass and pleural effusion. A biopsy was TTF positive adenocarcinoma. Unfortunately, staging MRI demonstrated multiple sub-centimeter CNS lesions. Soon after her diagnosis, pathology came back and NGS demonstrated that she had an EGFR deletion 19 mutation. So since it was 2014, at that juncture, she was started on erlotinib. She had a significant clinical and radiographic response and was feeling quite well. About a year later, she was noted to have minor chest progression. So at that juncture, we decided to do a blood biopsy. The vendor we used was Guardant, and she at that time was found to have the classic gatekeeper resistance mutation, T790. And so she was switched to osimertinib. She was on osimertinib for several years and then came to see us after recent progression on the agent. At that juncture, once again, we recommended blood and tissue biopsy.
Thank you, Jyoti. Before we go to the histologic findings, I thought it would be helpful to highlight to the audience an overview of the EGFR mutations in lung adenocarcinoma and testing for them. So these are present in approximately 10 to 15% of non-small cell lung adenocarcinomas. And the majority of the mutations are exon 19 deletions and the exon 21 mutation L858R. The recommendation by College of American Pathologists and Association of Molecular Pathologists is that there's no role for immunohistochemistry, and they recommend to testing for all hotspots within exon 18 to 21, the mutations that they have more than 1% prevalence. Here we have a question for our audience. What's the most frequent mechanism of resistance for first-line anti-EGFR treatment? And the answer, as many of you guessed, is T790M mutation, the one that our patient had here. So the mechanisms of resistance to anti-EGFR therapy for the first and second line is usually this mutation that we just mentioned, T790. And the patients, as Dr. Patel will tell you, they respond well to osimertinib. Resistance to the osimertinib is slightly different. There are secondary EGFR mutations, such as the most common ones being C797S or C24S, that can cause resistance. And for all of these, a biopsy of the secondary site can be considered, or a circulating tumor DNA nowadays. It's a very reasonable approach for detection of these mutations. Additionally, we can have the activation of other pathways in addition to the EGFR pathway that can cause resistance to this treatment, namely MET amplifications, HER2 amplifications, BRAF and KRAS mutations, and other pathway activations can be responsible for resistance. So to show you the pathology for this case, the 2018 biopsy was done in an outside institution, so I do not have that here to present to you, but a 2021 biopsy of this patient showed very similar findings, essentially adenocarcinoma, predominantly with acinar pattern, as you can see here. Predictably, TTF1 was positive. The NGS that at the time was done at the outside institution showed this exon 19 deletion with varying allele frequency of 31%, but surprisingly, there is a ROS1 rearrangement here that we consider these generally mutually exclusive with EGFR amplification in the primary basis, but this could be itself a source of resistance. Additionally, the MDM2 amplification seen here can also present itself as a mechanism of resistance to treatment. We have another question for the audience. Can immunohistochemistry be used as a confirmatory test for ROS1 rearrangements? Talk briefly about ROS rearrangement detect testing here. The preferred method of testing is FISH break apart. The PCR can be performed, but it's cumbersome and complicated because we have to know all the known partners, additionally all the breakpoints. So it's technically challenging. Next generation nowadays has become a reliable method for detection of ROS1 rearrangement. The recommendation by CAP and AMP is that clinical characteristics should not be used to exclude testing. Immunohistochemistry can be used as a screening test, but not as a confirmatory test. So this answers the question that you saw before. In other words, if you have a positive ROS1 IHC, then you need to confirm it with a molecular or cytogenetic method. And as I said, generally it's thought that at least in the primary setting, the ROS1 rearrangements are mutually exclusive with the other driver mutations such as EGFR or ALK rearrangement or KRAS mutation. So a sequential testing can be reasonable. Again, in the primary setting, not in this situation. As you saw, our cases define that rule.
So this case was exciting on so many levels. It really shows the evolution of what we've learned about EGFR mutant tumors. So now osimertinib is generally frontline therapy. And patients who become resistant are recommending repeat biopsy. Sort of the common, I think, denominator for these patients would be chemotherapy if we didn't pick up a fusion. But what's really changed and what is interesting about her is that the mutational spectrum changes depending, I think, on the length of time on some of these TKIs and whether patients had erlotinib followed by osimertinib or osimertinib alone. Certainly, we're picking up a few more fusions across the board, but this one with ROS1 is particularly unusual. So as you know, ROS1 has been a targetable mutation for some time. Crizotinib, a drug that was originally developed for MET amplification, is active in ROS1. Has been FDA approved. This drug is quite efficacious. We'll see response rates of up to 72%. And overall survival, at 4 years, which is over 50%. So certainly sort of an outlier. So we decided to try combination therapy. We had sort of two targets. And so she was started on dual agent of crizotinib and osimertinib. These drugs have some overlapping toxicities with QT prolongation, so we did so in sort of a very guarded manner, but she tolerated it well, and she was once again noted to have partial response. She did quite well, but unfortunately developed some progressive disease in her brain. Her chest disease and systemic disease was stable. So at that juncture, we sort of took a little bit of a gamble and thought about whether what was progressing in the brain was a result of what we were seeing, or resistance to osimertinib or resistance to crizotinib. And just that year, lorlatinib had been approved for patients with ALK, and we knew that lorlatinib could treat ROS1 tumors quite well. So we again changed up the targeted therapies and put her on dual TKIs, and once again, she had a pretty significant response in the brain. So we think about mechanisms of resistance to crizotinib in ROS1. It's certainly much less defined than what we know about EGFR for a couple of reasons. One, there are fewer patients with ROS1 translocations, and two, patients I think are on for a much longer time. But what we can say is we don't detect another mutation in up to 2/3 of patients. The other mutational variants in crizotinib refractory patients, I think the most common tends to be G2032R in about a quarter of patients, as well as these less known variants. Entrectinib is a drug that has been approved for ROS1, and it is approved in any line. It was approved this year. The advantage is that entrectinib has CNS penetration. And so in a patient with a ROS1 translocation at diagnosis, this would be, I think, the appropriate drug because of the CNS penetration. It is also a pan-Trk inhibitor and has been approved in that indication. If we look at Entrectinib in patients with ROS1 tumors, and again, this is really sort of on label in the FDA indication, in ROS1, we'll see a response rate of up to 75%. And this is, again, in contradistinction to Crizotinib, which has very low CNS penetrance. So we drew some blood biomarkers, and this is when I called Amir for help.
Really a fascinating case, really interesting. So as you can see, this patient has had 4 times of liquid biopsy, and following up the clonal evolution of disease through ctDNA has really helped us with precision oncology. And as you will see throughout various different cases that we present to you here, it's extremely a robust tool. So in this particular case, you can see that ROS1 rearrangement at no point has been actually detected in this case. So what the ctDNA is essentially showing us to us here is that you can see this bright blue column here, which is our T790M, is becoming undetectable after the patient gets started on osimertinib. We do have a tissue biopsy in the 2021 sample that I show you in morphology, and that essentially showed us a very high variant allele frequency of the EGFR T790M. One of the reasons this variant allele frequency is high is that this case also has an EGFR amplification. So there are a few variants here in this NGS that are of interest. One of them is the EGFR amplification. The other one is MTM2 amplifications, that they both can be mechanisms of resistance here.
Given these findings, it was a sort of a tough call as she's having a little bit of progression in her chest. We decided to hold tight. I think strategies given her EGFR amplification could be to double her osimertinib dose or try an EGFR-directed antibody should she need this, again, assuming that her CNS disease is controlled on lorlatinib. So really a fascinating case, and she's done so well with looking at these multiple time points.